Good afternoon, everyone. I'm very honored to be with you today. We're going to talk about a topic that is close to my heart. I will be sharing with you how digital orthodontics changed my life. I sincerely apologize for not being able to join you in person, but it's due to the troubles we are having in Israel right now. It has made traveling very difficult. However, I'm grateful for the technology that allows us to connect across borders, even in challenging times. In today's presentation, we will explore the exciting world of digital workflows, focusing on aligned technologies, innovative solutions, and how they are transforming orthodontics. Our aim today is not just to introduce you to these technologies, but more to unravel the paradigm shift it represents, to help you understand the potential impact on your clinic, on patient satisfaction, and the shape of the future of orthodontics. Before we dive into today's presentation, let me introduce myself. My name is Shadi Gera. I earned my master's and specialization in orthodontics from Aarhus University in Denmark, and I also have a master's degree in health administration and epidemiology. I work as an orthodontic consultant in the community clinic in Israel, and I run my own orthodontic practice in Jerusalem. I've been speaking for Align since 2019. I'm a Diamond Apex provider, having treated more than 1,000 cases. This is my private practice in Jerusalem, and it's limited to orthodontics. This is the university in Denmark. The department consists of 10 clinical instructors, 5 scientific staff, and we have 15 postgraduates, 5 per year. The department is unique in a sense that we don't have a teaching cookbook. We teach our postgrads different treatment techniques, and it's up to them to decide which one to use. I'm very proud to also say that we are very active on the scientific level. So why did I begin to work with the Invisalign system? I have started to work with Invisalign in 2015. The concept and innovation attracted me, where in my mind, it was a huge transformational change. It challenged the conventional way of how orthodontists move teeth. In my section, people were slightly hesitant over the efficiency and the predictability of Invisalign. It was something new, different. It was something out of their comfort zone. But today, I'm confident to say that clear aligners are my #1 choice of treatment. They have shown to be effective, reliable, and the best part, patients love the experience. The evolution of digital orthodontics. I think it's fascinating how Invisalign not only made orthodontic treatment more appealing, but also made it precise and efficient. The digital blueprint used by Invisalign allows us to plan treatment with accuracy, ensuring a comfortable and effective patient experience. AI has entered many aspects of our lives, and now it's making a mark on our profession. When we use Invisalign, we are not just treating our patients, we are also providing valuable data to the AI system. Each new case improves the system's learning and the machine's ability to suggest more accurate and efficient treatment plans over time. I think similarly, as we scan more patients, we are teaching the AI to understand the diverse range of oral structures and conditions. The AI continues to learn from the massive data pool we create, refining its ability to provide increasingly precise models and suggestions. Some may fear the AI, that it will replace us as doctors, but it's important to see AI as a tool, not as a threat. AI can never replicate the human touch, the patient-doctor connection, and our ability to make complex judgments. During the last decade, there has been a significant increase in the demand for orthodontic treatment using clear aligners. In the US alone, it's projected to reach $17 billion in revenue in the coming years. No one wants to stay behind. Let's take a look at the evolution of digital orthodontics at my section in Denmark. I'm showcasing how we've embraced technology over the years. Our digital journey started in 2004 with a very strict protocol for taking CBCTs. In 2005, with the adoption of digital models, by this marking the initial steps towards modernization. Fast forward to 2012, we began exploring the virtual orthodontic surgery planning. The momentum continued, and by 2014, we integrated indirect bonding techniques, streamlining the brackets placement process. Then came a significant milestone in 2015. We started to work with an intraoral scanner and clear aligners, and several CAD/CAM appliances afterwards. This is an example of a TPA and a lower lingual arch. Now, if we are working in the traditional way, whenever you have a patient, you just take records and you send the patient home. But for example, if you want to do a TPA, you have to have the patient in again, place separation elastics, send him home, ask him to come again, place bands, take an impression, send it to a lab, and only then you start the treatment. But in a digital way, you can design the appliance you want on a computer, 3D print it, and then start the treatment from day one. Being in a department that the legendary Birte Milson is your boss, we always needed to complicate things. For example, this case, class 2 large overjet, what we did is that we designed power arms, bonded them on the palatal side of the incisors, and then with a TPA, night-eye coils, we just retracted them to be closer to the center of resistance. But today, we can do it in a much easier way. So by aligners, by designing what needs to be done, you can have the posterior teeth acting as anchorage, and by this, pushing the teeth in the right position. Another digital appliance, the CAD/CAM Hierarchs, the design is done on a computer, so the precision is extremely high. Invisalign has introduced its palatal expander, and they have done that only a month ago. So it's the first direct printed device, and it will be the same concept as a rapid expander. A couple of years back, we were doing a lot of functional appliances in Denmark. So we wanted to have something more aesthetic for the patients to wear full time, even in school, because patients were quite complaining of having a metal bar in the twin block appliance. So what we did is that we designed an appliance which was milled from a block of acrylic. It was totally transparent, and the patient was wearing it full time in order to correct the skeletal relationship. In 2017, Align Technology, they introduced the mandibular advancement feature. So it's a pair of buccally placed reinforced precision wings, and they are integrated in the aligner itself. It replicates the mechanism of action of functional appliances. When the patient occludes, the precision wings engage, by this keeping the mandible in a more forward position. To make it interesting, let's take a look at a case. This is Adam. He's 12 and a half years old, and he's complaining of the crowding in the upper arch. Looking at his profile, we can see that he has a retruded mandible. Looking intraorally, class 2 on both sides, crowded upper arch, and with a slight deep bite as well. These are the models and the ClinCheck, the treatment plan. So if you take a look at what is happening, we have 50 aligners in total. At the same time, we are unraveling the crowding, expanding the upper arch, and at the same time, we're advancing the lower arch gradually, not at once. So it makes the treatment more comfortable for the patient. And at aligner number 50, the two jaws will snap in place. This is how it looks from the buccal views. So you can see that the shape of the aligners is changing with the wings. Every 8 aligners, we have one step moving forward until we have a bit of overcorrection with the sagittal. And only then by aligner number 50, the aligners will snap in place. This is how it looks from the occlusal view. So we can move all teeth that is not present under the wings itself. So we can expand and we can unravel the crowding. So we are doing two things at the same time. And this is the result that we've got. We achieved all the treatment goals, class 1, both canine and molar, and we finished the treatment with fixed retainers. This is the shape of the upper arch. The difference you see on the patient's smile. Let's take a look at another case. This is Freya. She's 11 years of age, and she's concerned about the upper arch crowding. Looking at her smile, she has a non-consonant smile. Looking at her profile, it seems that she has a mid-face hypoplasia. These are the intraorals. This patient has already been treated with a Hyrax and a face mask, and she was being monitored for retention, and during this time, she relapsed, so we had to intervene. So what we did is we constructed a 3D appliance connected to mini screws, 2 in the upper arch, 2 in the lower arch, and the patient is wearing class 3 elastics. These are the appliances. The lower is constructed of 3 parts. We have 1 on each side and 1 just maintaining the front teeth. This is how it looks in the patient's mouth. And this is how the patient is placing the elastics. So this appliance allows for 24-hour elastic wear, not like the face mask. And straight after we correct the sagittal, we just align the teeth in the proper position. So we never feel confident in extracting 2 premolars in the upper arch in a class 3 patient. But in this case, because the correction was done in a very efficient way, we could do that. This is a cephalometric analysis and the profile of the patient. It's a huge change before and after. The sagittal-skeletal relationship significantly improved. And this case has been published at the AGODO. Now, our clinical work as orthodontists is based on the principle that is called evidence-based dentistry. which is composed by these three features: research, clinical expertise, and patient values. The whole medical world is shifting towards a patient-centered care. Historically, the relationship between the doctor and the patient was defined by a paternalistic hierarchical model, where the doctor knows best, and by this silencing the voice of the patient. The other end of the pole is the consumer-driven model, establishing a kind of a contract relationship between the buyer, the patient, and the seller, the doctor. In this setting, the buyer knows best, and the payer is asking for what they want, not what they need. By this, the buyer's wrong expectations, they are silencing the voice of the evidence-based doctor. So both of these models are flawed. So what exactly is a patient-centered care? Patient-centered care is not just about giving patients what they want or educating them about their needs. The most important thing is to establish trust and credibility with the patient. We should be embracing patients as a person, not just as a case. Patient-centered care means that we need to recognize that we are guests in the patient's life. We need to value the patient's opinions. We should engage in active listening and share discussion-making. It also means complete transparency. The care team should offer a full, unbiased information about the options, benefits, and the risks of the treatment. In an editorial published in the Engel Journal back in 1993, Dr. Turbin asked himself and the readers what orthodontic patients really want. He said that it's very rare for patients to come into our offices in order to correct a malocclusion or correct a functional problem, but they come to correct an aesthetic problem. He stated that patients want a smile that is transmitting confidence and enthusiasm. Some years later, a group from Alabama University in the States, the authors rated the smile attractiveness of patients finished to the American Board of Orthodontic Standards. Their sample size was 68 cases. So you know that everyone who wants to become an orthodontist in the US needs to submit cases for review for the board. So these cases are supposed to be your best cases. The results were really surprising for me. They show that only 2 out of 68 had an attractive and a perfect smile. So this means that our standards are completely different from patient standards. Now, the very important question that we need to ask ourselves is orthodontic treatment matching with the patient's requests? Following these findings, a systematic review evaluating lay people's perception of smile aesthetics have been published. So you know that a systematic review is very high in the evidence pyramid. So here are the results of the review. So the group was able to find quantitative values, cutoff values, and level of acceptance of different things. So they looked at the diastema. The ideal, we should have no diastema. Overbite, the ideal should be 2 millimeters, but there is a tolerance between 2 to 5 millimeters. Midlines, they should be corresponding, but we have a tolerance of 1.4 and 3.4. Incisal edge difference, so the ideal is 1.2 and the tolerance is 1.1 to 2 millimeters. Gingival display, the ideal is 2.5 millimeters and the smile arc 2 millimeters. They put these values in a graph and they put them in 3 different areas: area with high acceptability, high tolerance, moderate acceptability and medium moderate tolerance, low acceptability and low tolerance. So if you take a look, the midlines, they have a high tolerance. And this is what we're always saying. The deep bite, patients, they never smile with their teeth closed. So patients don't pay attention to all of these. But the most important thing is the level of the incisal edge between the laterals and the incisors and the smile arc of the patient. So why did I go into all of this? I think doing and planning in a digital way, it makes us closer to a patient-centered care. It will make it easier for us to address the patient's problems and show him from the beginning how it would look like. Align, they have also introduced the Smile Architect. So it's a new facially driven ortho-restorative treatment planning platform. And it provides a single ecosystem for combined visual treatment planning plus a restorative option. This is how it looks like. We can move teeth around, so all the 3D controls are also present. And then we can see the restorative results afterwards straight away. Now, the traditional way of orthodontic treatment planning focuses primarily on occlusion and the aesthetics of the teeth alone, while in recent years, contemporary orthodontic treatment has evolved, taking into consideration how the proposed treatment will affect the aesthetics of the patient's entire face and the dynamics of the smile. Just to demonstrate the importance of a correct diagnosis and planning, take a look at this case. The woman on the right is 40 years old. The photo on the left is taken only 1.5 years after. Look at the lack of support of the upper lip and her ditched-in face. It made her look 10 years older. We should look at macro aesthetics at the face, at the profile, mini aesthetics at the lips, at the gums, at the incisal display, and micro aesthetics, the surface texture, taking into consideration how the proposed treatment will affect the aesthetics of the patient's entire face. Let's take a look at another case. This is Dirula. She's 50 years of age, and she came to me wanting to improve her smile after I finished treating her daughter. Her teeth were perfect, so she wanted the same. Looking at her smile, we can notice that there is something weird going on with the central incisors. It's an asymmetric smile, but overall, she's harmonious on the profile. Looking intraorally, we can instantly notice that she's done an orthodontic treatment before because she's missing 2 premolars in the upper arch and she is missing an incisor in the lower. Looking at her, she's class 2, deep bite, crowding both upper and lower. These are the initial models, and this is the planned treatment. So what we are trying to do, we're trying to correct the deep bite by absolute intrusion in the lower arch and in the upper arch, proclination, and then intrusion. In total, it's 23 aligners. Now, examining this patient, and from the initial examination, I could tell her that we can definitely align her teeth, but it's not going to give her what she wants. In her case, we need a combined ortho-restorative to give her what she wants for So it's very important to talk about expectation at the initial consultation with the patient. This is how it looks like from the occlusal view. So we're unraveling the crowding by proclination. You can see IPR as well, posterior and anterior in the lower, because that's where we had more crowding. And this is the final result. We managed to align teeth. All teeth are in the proper position. It looks nice. We managed also to solve the deep bite. This is from the occlusal view. And this is the smile of the patient. Again, as I told you, expectations. So I knew that this patient had high expectations. So I told her we'll definitely have to do veneers afterwards. And this is how she looks like after treatment and after veneers. She looks like a totally different person. So the right after treatment, the left after veneers. And this is the progress before treatment, after orthodontic treatment, and after veneers. Her new smile gave her confidence, and she started to take better care of herself. Let's take a look at another case. Nathan is 26, and he came wanting to improve his smile. Looking at his smile, he has an asymmetric smile, non-consonant smile as well. Looking intraorally, of course, we see that he is missing a central incisor. He has all the problems you can imagine that are present in an orthodontic book. So he has a crossbite. He's a subdivision class 2. He's class 1 on the left side, class 2 on the right side. Anterior crossbite, crowding in the lower arch, upper and lower. These are the models. And this is the panoramic X-ray. So one of the powers of digital planning is that we can discuss and show the patients. In this case, we have two options. We can either open space for the missing incisor, or we can shift the midline and reshape the lateral incisor into a central incisor. So in this case, I chose to open space. This is how it looks like in the ClinCheck software. So we have 40 aligners. What is happening is that we are sequentially distalizing in the back because we need space to open for the missing incisor. We are expanding at the same time. Whenever we have the proper space, only then we start opening space in the incisor. This is how it looks like from the buccal views. So you can see that we are sequentially distalizing one tooth at a time. Whenever the canines are in class 1, only then we start opening for the missing incisor in the front. From the occlusal view, IPR to unravel the crowding in the lower. Whenever we are distalizing in an adult patient, I always combine it with posterior IPR in order to distalize less, so it becomes more predictable. So 40 weeks of treatment, and we've got this. So the good part is that the patient doesn't need to go around with having a space in between the centrals. So we can have tooth-colored material in the aligner itself. When the patient is placing the aligner, no one would notice that he's missing a tooth. This makes the patient even more compliant with the treatment because he's wearing the aligner all the time. For those of you who wanted to shift the midline and reshape the lateral incisor, This is how the ClinCheck would look like. I haven't chosen this treatment modality because we have the labial frenulum. And whenever we shift the midline, the labial frenulum is going to be oblique. So his smile is going to look a bit weird. Of course, we can overcome this with a frenectomy. Digital workflows. So the Align digital workflow enables an end-to-end treatment experience. It streamlines the treatment process from start to finish. Quicker and more precise treatments, integrates virtual treatment planning, and easier communication between the dental team and the patients. Initially, like many, I was hesitant about learning and associating or adapting new technology. But integrating an intraoral scanner into my practice has been a rewarding process. Precision and accuracy. Increasing the precision of my diagnosis and treatment planning, improved patient experience, greatly enhancing my patient's comfort and experience. The visual nature of the technology also helps the patients being educated, promoting better understanding and cooperation, efficiency and productivity, reorganizing the workflow in my practice, allowed me to see more patients and focus more on personalized care. So if I just want to sum up, I would say adopting an intraoral scanner has enhanced my clinical practice, my relationship with my patients, and my own professional development. All of this is making me a better orthodontist every day. I will outline a 5-step process, the optimized digital workflow. It starts with an iTero digital scan. Always start with a scan. I start to take a scan even before I look in the patient's mouth. Why would I look with my own eyes one tooth at a time when I could see everything on a 55-inch monitor in HD? I see better with an iTero scanner than my own eyes. Now, if you take a look, all of these except the clinical data can be done by someone who is not a dentist. Buying an iTero scanner is one of the best decisions I made in my career. You will see now how with one scan, it will help you with patient engagement, evaluation, diagnosis, and treatment planning, taking all of this to a whole new level. So the iTero scanner has transformed the orthodontic landscape, making it a true game changer. In general, these are the benefits of an iTero scanner. So today's scanners are much more than just a replacement of impressions. Patients visualizing their own problems. It's an incredibly powerful tool. So I would say that it even changed the way we communicate with the patient. The conversations became much more engaging. We can use it for education, for prevention. It easily lines up with the clear aligner workflow, and it can be used for your rehabilitation and external lab communication. For over 200 years, we have been looking at teeth one at a time in a reflection of a dental mirror, which is the same size of a coin. Now, for the first time, we can see the dental system as a whole. Visualization here is extremely key. And why I say visualization is key? Because no longer are words cutting it in a sense. Our brains are built for visual information. Think about it. 90% of the information that is processed by our brains is visual. So to process an image, it takes 13 milliseconds. So what happens is 80% of individuals remember what they see, 10% remember what they hear, and 20% remember what they read. The touch screen on the scanner interface allows us to demonstrate our observations to the patient in a way they understand. Now, for the first time, they can see their own problems on screen in color. There is no hiding from it. One 3D scan gives you a range of powerful visualization capabilities for an optimum patient experience. And we're going to go through them now. The iTero Element 5D imaging system is the first intraoral 3D scanner integrated with near-infrared imaging. This technology has been proven to be excellent in early detection of interproximal caries. The iTero Element 5D uses a special wavelength which interacts with hard tissue. The dentine will appear bright. Areas of pathology or demineralization appear white spots on the display. With this tool, the reliance on trusting the dentist is becoming less and less. Patients trust what they see. Here you can see proximal caries on the premolars. So healthy enamel appears dark, while proximal carious lesions appear bright. Here we also see caries on a distal of tooth number 14 and the mesial on tooth number 15. Invisalign Outcome Simulator. This tool will enable both doctors and patients visualize the desired outcome of their treatment. So this is how it works. The scanner is smart enough in a way that it can segment teeth. It can choose the long axis of every tooth. And by doing so, it can separate the teeth from the gums and align them in the most precise way. By doing so, we can modify the simulation. We can do extractions, we can do IPR, or we can correct the anterior posterior. So we can change our treatment goals and we can show it to the patient. The advantage with this is that patients tend to get an emotional attraction to their new them, by this increasing the number of acceptance for treatments. So as you can see on the video on the screen, this is how it works. It will show you a simulated outcome with the current dentition, showing you all the differences. In the latest scanner, the 5D Plus series, we have the Invisalign Outcome Simulator Pro. So instead of just simulating how the teeth would look like, we can transfer the simulation to the patient's entire face and showing him how his teeth can look like after treatment. In order to do so, we start just by taking a photo from the Invisalign Practice app, and then it will be automatically updated to the scanner. Once the scanner finishes processing, the new smile design will be present there. This is the Invisalign Practice app. From here, let's take a look at a case. This is Mirab. She's 41 years of age, and she came wanting to improve her smile. Looking at her smile photo, we can see that she has black triangles, so narrow upper arch. She has a chipped central incisor, but quite a harmonious profile. These are the intraorals. So class 1, both right and left. We can see lower arch crowding. And if we look close enough, we can see that the lower central incisor is occluding exactly where the chipped incisor is. So in such a case, we cannot just do a restoration. We need to align the teeth first, make space, and only then build the incisor. These are the initial models. And this is the ClinCheck. You can see that the lower incisor is occluding exactly where it should be. So even if we wanted to build it out, we cannot do that. It's not possible. It will break the next day. So we align the teeth, we expand the upper arch. And this is how it looks like. This is from the frontal view. You can see the amount of expansion. We're correcting the midlines, leveling and aligning it. From the buccal views, you can see that we are stabilizing the posterior teeth, so nothing is happening. This is why I chose that it's a moderate case. Moderate case is limited to 20 aligners. And this is the final result. So we can see that when we have space, we manage to build the incisor. And from here, how to know that my treatment is going in the right direction. So we have on the scanner a progress assessment tool. So what it does is that whenever we have our patients coming for a control appointment, we scan the patient, and the scanner will superimpose the current stage he is in with the planned stage on the ClinCheck software, and it will bring a color code on how is it going. Is it going in the right direction if the teeth are tracking, or the teeth are not tracking, or there is no significant movement detected. And this is the result for my patient. You can see that everything is green, so it means that the case is tracking according to plan. And this is the Outcome Simulator Pro, how her teeth would look like. And this is the actual result, how her teeth looks like. So again, huge difference. We managed to expand the upper arch as much as we can. So 2 millimeters on every side, just to try and reduce the black triangles. Now, with the introduction of the DSD concept, dentists and orthodontists want to show their patients a realistic simulation of what their new smile could look like. While there are a number of products and softwares in the market, many require training and they require time to deliver. I think the dream of an instant app that delivers a believable outcome is what dentists wish for. Now, this is how we could show our patients how it looks like. So we print a barcode from the IDS website. We post it on social media. We print it and put it and hang it in the clinic. So all patients can scan the barcode and it's done automatically. Let me show you a couple of smiles that has been generated in 60 seconds. So before and after. As I said, the problem with many applications is that they have a tendency to create a smile that looks glued in the patient's face. So these smiles don't resonate with the patient himself. This patient, after coming and doing the smile view for him, he asked me if he could have the app in order, because he wanted to change all his photos in all of his albums. So it looks quite natural. Another patient presenting with an unsymmetric smile. So these patients closed or accepted the treatment instantly. Invisalign Practice app is a useful tool as well. So we take photos, they are automatically uploaded to the cloud. and the in-face visualization. This is a more accurate way of doing a digital smile design. So it's showing the patients what their smile can look like in a more accurate way according to the movements that are being done on the teeth. So before and after, before and after. It can also correct anterior-posterior relationship. So this patient has a proclined lower incisors, making him into a class 3 tendency. And with the software on the ClinCheck platform, we managed to correct that. So before and after. iTero time lapse. With the time lapse, it becomes very easy to show patients any change in their oral condition. So what is done is that we have a scan, 2 scans in 2 different time points, and then it will superimpose them with a color code showing the differences before and after. This is useful in cases where we have attrition, for example. As you can see here, we just drag the magnification glass on the tooth, and it will show you how his teeth were before and how they are right now. Virtual care. Invisalign virtual care. This is one of the tools that are most useful about treating patients with clear aligners. So I tend to see my aligner cases every 3 months. But then some patients, especially teen patients, they lose compliance because they're going to say, I'm not going to see him for 3 months. But actually, I ask these patients to take photos with their phone using the Invisalign app, and then these photos are going to be transmitted to me. Now, at the beginning, I was checking 1 photo at a time, but now we have AI. So AI is detecting if the aligner is tracking or not according to a threshold that you assign. So if we have any problem, we will get a notification, and by then we can send messages to the patient, or we can call him in to come for an appointment. The last part of my presentation is fixed appliances versus clear aligners. This is to show you the innovations that Align has to solve different problems. Treating orthodontic patients with Invisalign require a shift in the thought process from being a reactive orthodontist to being a proactive orthodontist. As orthodontists, we are trained to be reactive. We always make a small adjustment to the appliance with either changing the arch wire or making bends. Then we wait 4 weeks, and based on the patient's response, we take another treatment decision, moving 1 step at a time. Clear aligner technique requires a more proactive, disciplined approach. Before starting to move teeth, the final result is already in sight. It's in front of us. And the correction of the malocclusion is already visualized, and the final occlusion is already designed. So we should always remember that Invisalign treatment is an orthodontic technique. It's not a product. Just as other techniques that we have in our toolbox, exactly as labial or lingual braces, all orthodontic principles of force, engagement, anchorage, and biomechanics, they are still applied. At the same time, clear aligners move teeth differently than fixed braces. For this reason, a clear understanding of the similarities and the differences is essential. There's a major difference between the way brackets and arch wires move teeth compared to clear aligners. As a rule, fixed appliances, they pull on teeth, while clear aligners, they push on teeth. If you take a look at this case, it shows that the arch wire is engaged. The elasticity in the arch wire causes the arch wire to return to its original arch form. As the arch wire returns to its original shape, it pulls on the tooth to move into the arch. In contrast, aligners move teeth by exerting a push force. When an aligner is inserted over a tooth, the aligner deforms, and the elasticity in the aligner material pushes the tooth into position. If you add to all of this the influence of the optimized attachments, in which they provide an active flat surface that the aligner can push against, especially for movements such as extrusion and rotation. What differentiates Invisalign from other aligners out there is that it's a force-driven and not a displacement-driven system. In a displacement-driven system, the aligner is fabricated with the exact shape of the crown of the following stage of the treatment. And it considers that the tooth will move until it lines up with the shape of the aligner. The displacement-driven system concept is effective mainly in tipping movements, but is less effective in controlling the movements of the roots. So in a force-driven system, the aligner is made in the shape that is intended to give a specific force to the tooth, leading to the desired movement. You all know the orthodontic literature is full of articles defining the force system necessary to achieve different types of movement. For example, tooth tipping, a single force applied to the crown will do the job. But if the movement needed is a controlled tipping, translation, or root movement, the aligner must deliver the correct force. And with the force, it should deliver also a moment. With Invisalign, the movement required for each individual tooth from the beginning to the end of the treatment is integrated into the ClinCheck software. The software then determines the type of the movement, and the algorithm will calculate the force system. Then the shape of the aligner will be determined accordingly. Anchorage is the resistance to unwanted tooth movement. Knowing how to handle it can make our life easier, and it would be easier to achieve our treatment goals. In fixed appliances, the most common anchorage model is that of a reciprocal anchorage. Based on Newton's third law, for every action, there is an equal and opposite reaction. Where one segment of the teeth act as an anchorage unit for the rest of the teeth. For example, in a first premolar extraction, when we want to close the space, the posterior teeth act as an anchorage segment for the anterior teeth. At the same time, the anterior teeth act as an anchorage segment for the posterior teeth because the root surface area is larger than that of the anterior segment. The anterior segment will retract more than the posterior segment will move forward. In clear aligner treatment, the anchorage segment can be predetermined and may change at different stages of the treatment, making clear aligners offer extremely good control of anchorage because the anchorage teeth can stay fixed at different stages of the treatment. For example, in asymmetric expansion, one side of the mouth can be used to expand the other side. Also, in sequential distalization, only the second molars in the initial stages of the treatment can be distalized, while the remaining teeth in the arch from first molar to first molar do not move and act as an anchorage segment to push the second molars distally. In 2015, Align introduced the G6 protocol for extraction. In this protocol, the posterior segment and the canine move first, while the incisors, they don't move at all. And they act as an anterior anchorage segment to distalize the canine into the extraction site. At a certain stage in the treatment, the second premolar and the molars stop moving, and they become a posterior anchorage segment. Canines will move up to 1/3 of their total movement, and at that point, incisors retraction will be started. Let's take a look at a case. This patient came to me wanting to improve her smile. She actually was looking to do veneers. But looking at her profile, we can see that she's bialveolarly protruded. Looking intraorally, this patient has undergone an ortho treatment. She has fixed retainers. What they did is that they proclined as much as they could. This case definitely needs extractions. But looking that it's an asymmetric case, she's class 1 on the left side, class 2 on the right side, we need to consider which teeth to extract. And again, with the power of digital planning, we can have a simulation of either 4 premolar extractions or 3 premolar extractions. This is the panoramic X-ray, and this is the initial simulation that I made. She's asymmetric. You can see the midlines are not corresponding. We got 45 aligners. So what is happening is that the teeth are being moved into the extraction site, and we're retracting the incisors as well. Looking from the buccal view, you can see that we're using the space again to retract the incisors, but the only space that is not necessary is the one on the lower right side, because we're using the whole space to mesialize the posterior segment. And we know mesialization is not a predictable movement with aligners. So this got me thinking to why not have a different sequence of extractions? Why not have a 3 premolar extraction? So we extract 2 on the class 1 side and 1 on the upper side to maintain the class 2 and only move the canine into class 1. So this is the simulation. Just by having the correct diagnosis, we managed to save 10 weeks of treatments. So now we have 35 aligners. You can see it's even easier to correct the midline because we have space only on one side, shifting the midline in the correct way. This is how it looks from the buccal view. So again, reciprocal anchorage on the left side, maximum anchorage on the right side. The patient is wearing class 2 elastics as well for anchorage purposes. This is how it looks from the occlusal view. So you can visualize the amount of retraction that we had in the front. So we're using the space to retract. And you are seeing also the correct of the midline in the lower, because the teeth are moving more to the left side where we had the extraction. 35 aligners only, and we managed to get this. With fixed appliances, this is gonna take 2 years. So this is insane. So after we reach this result, we still had a bit of black triangle. So I said, why not fix it as well? So in this case, we scan the patient and we have refinement aligners. So in this case, we have IPR. So the IPR is made to reduce the black triangle. So to remove the contact point and make it as a surface contact, 12 more aligners. And this is how it looks like. So just very minor movement. And if you notice that the 8th, the wisdom teeth have came to the arch. So now we can align them as well, because they were not part of the treatment at the beginning, because they were slightly impacted. And this is the final result. It's amazing. There is no other word to describe it. Maybe we can describe it as magic. Fixed appliances engage teeth using an arch wire ligated into the bracket slot. The thicker and the more rigid the arch wire, the better the engagement. The arch wire sequence starts from round, flexible wires with a long working range and high elasticity, and gradually move towards a rigid rectangular stainless steel arch wires. Now, in an arch wire that approaches the size of the bracket slot, the tip torque in and out, and they are all built into the bracket slot. Clear aligners engage teeth by having aligner material wrapped around teeth. The more aligner material wrapped around the tooth, the better the engagement. In teeth with long clinical crowns and large surface area, there is a better engagement and better expression of tooth movement. On the contrary, in teeth with short clinical crowns and less surface area, there is less engagement and less expression of the tooth movement. One way to increase the engagement, for example, lateral incisors, is to place an attachment. This increases the surface area of the tooth and therefore increases the engagement of the aligner to help the tooth the movement to be expressed clinically. In cases where sequential distalization is planned, it is crucial to register the distal surface and the distalmost tooth in the arch, so that the aligner can fully engage that tooth to distalize it. Extrusion. In fixed appliances, extrusion of a single tooth can be accomplished relatively easy. However, because the teeth in the arch are connected by an arch wire, there are reciprocal movement on the adjacent teeth. This may create temporary cant in the occlusal plane. Eventually, as the teeth progress into more rigid arch wires, the occlusal plane will be leveled out. In case where reciprocal tooth movements are undesirable, it can be avoided using an overlay system by placing a rigid arch to stabilize the teeth and a flexible night-eye wire as an overlay to extrude that tooth. With clear aligners, extrusion of a single tooth is a moderately difficult tooth movement. It depends on the amount of extrusion required. If more than 2.5 millimeters, we might start to consider auxiliary help. I even write the technicians to create minimal spaces before the extrusion, and we close these spaces after the tooth has been extruded. Extrusion of a group of teeth is considered a fairly predictable movement with aligners. Back in 2012, Align, they announced their G4 innovation, which includes multi-teeth anterior extrusion attachments for the anterior open bite correction. This innovation, together with the possibility of intrusive mechanics of the posterior molars, makes clear aligners the orthodontic appliance of choice for correction of anterior open bites. So whenever we have an open bite, we need to look at the incisors. If the incisors are flared, just by retracting them, we get relative extrusion and we close the bite. Whenever teeth are upright, we need to look at and examine the amount of incisal and gingival display. It needs to be assessed in order to decide what needs to be done. But extruding these teeth is called absolute extrusion. Now, if we want to close the posterior open bite by posterior intrusion, this is how it's done. So the teeth are being intruded into the arch, creating a gap between the two jaws, and then it will be followed by a simulation jump, an auto rotation of the mandible. This is how it looks like in the prescription form. So you get to decide if you want to extrude anterior teeth only or combine it with intrusion in the back. These are the multi-tooth extrusion attachments, and they are placed automatically whenever we want to extrude a tooth more than 0.5 millimeter. This is the complexity assessment of potential open bite cases. So we look at the amount of intrusion and extrusion that we need, and according to this, we can assess the complexity of the case. From here, let's take a look at a case. This is Itik. He is 22 years, and he's concerned about his anterior open bite. You can see that he has an increased lower facial height, so this might indicate that he's an open bite patient. Looking intraorally, again, crossbite, anterior crossbite, inverted laterals. He's class 1 on the right side, class 2 on the left side, and upper and lower crowding. These are the initial models, and this is the plan. So usually, because we are distalizing, no movement needs to be done on the anterior teeth. But in this case, the patient was in a hurry and his anterior alignment was bothering him. So I asked the technicians to have an aesthetic start. By this, while we are distalizing the class 2 side, we are aligning the front teeth as well. You can also see the expansion that is happening. Let's take a look from the buccal side. So on the class 2 side, we can see a linear movement, both distalization with a bit of expansion and intrusion, but everything is moving in the same line in order not to get hyalinization. And when we get hyalinization, we get a stop in the movement. The movement is not going to be expressed. This is from the occlusal view. You can see the amount of expansion with the distalization. Everything is done sequentially. So the distalization and the expansion, one tooth at a time, in order for the movement to be more predictable. 45 aligners. With 45 aligners, this is what we get. So the teeth are aligned. We managed to reduce the anterior open bite, but still, this doesn't look perfect. So in this case, after 45 aligners, we had 16 additional aligners. We are having IPR just to reduce the black triangles because of the amount of crowding that he has, so it has never developed. And we are having retraction by the IPR that we have been doing, by this having better overlap of the incisors. And at the same time, we are continuing with the intrusion in the back. You can see it from the buccal views. You can see the amount of intrusion. And at the end, aligner number 16, we will get the auto rotation and the closure of the anterior open bite. Nothing on the occlusal view because it's very minor retractions of the incisors, just the IPR to reduce the black triangles. And this is the final result. So we corrected the anterior open bite by a combination of posterior intrusion and incisor extrusion as well. Because the patient, if you look at him before and after, he had a reversed smile. So after treatment, his incisors in the upper arch are going with the lower lip, with the curvature of the lower lip. Intrusion. In fixed appliances, the dental arch is leveled through relative intrusion. Anterior teeth intrude, posterior teeth extrude. This makes segmental intrusion challenging, needing a careful management of the posterior anchorage through transpalatal or lingual arches to manage any unwanted reciprocal extrusion of the posterior segments. Clear aligners offer an extremely good vertical control. It's considered predictable to intrude successfully entire segments of teeth. This is how it looks in the prescription form. So whenever we have a deep bite, we can correct it either with intrusion of the anterior teeth alone or intrusion with a possibility to extrude the posterior teeth. This is the complexity assessment table. So to help with correction of the deep bite, to help solve deep bites, in 2014, Align Technology launched their deep bite protocol. It includes pressure areas, optimized deep bite attachments, and precision bite ramps. So the pressure areas and the optimized deep bite attachments, they are designed to level the curve of spay by improving control of anterior intrusion and premolar extrusion. The optimized support attachments are designed to support incisors and canine intrusion. The precision bite ramps are designed to disocclude the posterior teeth for improved efficiency, and they would allow the posterior teeth to extrude. Clear aligners have always performed well with intrusion. Because of the aligners material, it's engaging the tooth from the occlusal, buccal, and lingual surfaces. However, for example, on the incisors, whenever we want to have an intrusive force, the intrusive forces may not be directed through the long axis of the tooth. So to address this problem, Align developed pressure areas or concavities designed into the aligner surface. They are placed at the lingual cingulum area on the incisors. These pressure areas allow the intrusive force to be redirected through the long axis of the tooth. Optimized attachments on the premolars, they are designed to provide anchorage for incisor anterior intrusion. Now, these attachments can be activated to deliver an extrusive force when needed. The precision bite ramps to disocclude the posterior teeth, because the posterior bite forces can work against deep bite correction. Precision bite ramps can be placed on the palatal surfaces of either maxillary central incisors, lateral incisors, and maxillary canines. These precision bite ramps are lingual prominences incorporated into the aligner itself at the level of the cingulum. It was found clinically to have up to 30% more intrusion from data coming from Align. Previously, you should have asked for them, but now they are automatically placed whenever we want to correct more than 4 millimeters of overbite, or if we require more than 1.5 intrusion. Let's take a look at a case. This is Rana. She's 32 years of age, and she's concerned about the gummy smile. So looking at her, it looks like she has a quite symmetric smile, consonant smile, good proportions. She's harmonious. But looking intraorally, you could see the problem. She has a deep bite. She's class 1 right and left, but she has a deep bite. But what is comforting fact for me is that the incisors are retroclined. So just by proclining, we can help with correcting of the deep bite. These are the initial models. And this is the simulation. So you can see first we are proclining. Once the teeth are in the right position, only then we start with intrusion. This is how it looks from the buccal side. So you can see the proclination, both upper and lower. And whenever teeth are in the right position, we have a bit of more intrusion. You can see from the occlusal surface. So easy case, light case, 14 aligners. In this case, I felt safe to do only 14 aligners because the patient has a combined treatment. She wanted veneers afterwards. So if anything else needs to be corrected, we would correct it in the prosthetic phase. This is a start of treatment, end of treatment. You can see that the teeth look really nice. We managed to intrude the teeth, less gummy smile. You can see the gums are a bit inflamed on tooth number 12, but that's not a problem. If it was me, I would be happy like this. I wouldn't go further doing veneers, but the patient wanted white teeth. So yeah, non-prep veneers were placed there. They look really nice. Before orthodontics, after orthodontics, and after veneers. So we did a bit of gingivectomy on that tooth. Now, torque. In fixed appliances, torque is built into the bracket slot. The amount of torque expressed is related to the size of the arch wire and the amount of torque built into the bracket slot itself. There are many types of different prescriptions for different bracket systems. Some clinicians will use different torque prescriptions for individual patients depending on the initial malocclusion. Additional torque can also be added by making torque bends on the arch wire itself. Now, clear aligners are very efficient in managing torque using power ridges. The incisor torque in the finished occlusion can be predetermined subjectively for patients depending on the initial malocclusion and the desired final outcome. This is how it looks like. So a power ridge is an indentation in the aligner itself. And we have two of them, one on the buccal side, one on the palatal side, from two different sides, two different force, by this creating a moment. So by this, it will help correct the torque of the incisors. Let's take a look at the case. This is Daniel. He's 15 years of age. Looking at his profile, the thing is that I could see that he has a protruded chin. But looking intraorally, he's a class 2 patient. Deep bite, so he's a class 2 on both sides with a deep bite. These are the intraoral, the initial models. So slight crowding, both upper and lower, class 2 molar relationship, and a deep bite. And this is how I decided to solve his malocclusion. So we are proclining the incisors. At the same time, we are distalizing the posterior teeth. This is why you don't see a lot of things happening on the simulation, just the proclination. And then the retraction. So proclination, intrusion, and the patient is wearing class 2 elastics. So at the beginning of the treatment, the patient is not wearing elastics in order to help with the proclination, because the class 2 elastic will work against the proclination in the front. And whenever the premolars start to distalize, only then for torque purposes, I ask the patient to wear elastics. So this is the rationale table for placing hooks versus button cutouts. We look at the incisors. If the teeth are proclined in the maxilla, we place a hook. If the teeth are retroclined, so we place a button in order for the force to be only on that tooth, not transmitted on the whole aligner. In the mandible, it's the exact opposite. This is the simulation before and after. Very nice result. And the smile of the patient. We didn't make his chin worse by the class 2 elastics because we had a lot of distalization built in. Sequential distalization. I consider distalization as the secret weapon for aligners. It's so powerful and it's a very predictable way to correct class 2 malocclusions. This is how it looks on the prescription form. Class 2 elastics are worn to reinforce anchorage and to aid tooth movements already built into the aligner. This doesn't necessarily mean that there will be a simulation jump to correct to class 1. If you look at the staging tab in the ClinCheck software, you'll see a V pattern staging. Only the second molars are distalized in the initial stages of the treatment. The remaining teeth in the arch from first molar to first molar, they do not move at the initial stages, and they act as an anchorage segment to push the second molar distally. In order to demonstrate this, I'll show you a case. This is Catherine. She is 18 years of age. The chief complaint is that she has sticking out teeth in the front. If we look at her profile, she has a harmonious profile. Looking at her smile, she has a consonant smile, but her teeth are a bit sticking out of the mouth. Intraorally, she's a subdivision. She's class 1 on the left side, class 2 on the right side, midline discrepancy, and a large overjet. You can see those on the model as well. So class 2 on the right side, class 1 on the left side, crowding both upper and lower, and midline discrepancy because of the asymmetry that she has. These are her models, and this is how I'm treating her. You can see nothing is happening in the front, so we are distalizing one tooth at a time on the right side. We're maintaining the left side, and the patient is wearing class 2 elastics for anchorage. Whenever we have space, only then the midline is going to be shifted. So 40 aligners, the initial stage of the treatment. If we look at it from the buccal view, you can start seeing the distalization on the right side. So one tooth at a time. When the 7 moves halfway, only then the 6 start to move, and then the 5, 4, and then the front teeth all together. And the patient is having class 2 elastics. This is how it looks from the occlusal view. So as you can see here, nothing is happening in the front. Very minor distalization on the left side, mainly expansion, just to get better interdigitation between the two jaws. 40 aligners, and this is the result that we've got. So the teeth are quite aligned. We minimized the overjet, but still we have a problem with the midlines. The midlines are not corresponding. So at this stage, we scan the patient, we order refinement aligners. We have IPR on the lower left side to help to correct the midline. So 16 more aligners. We have extrusion attachments on the lower incisors just to have better overlap between the upper and the lower. And this is the final result that we've got. So midlines are on. We have class 1 both on the right and on the left side. And we can see this also on the smile of the patient. She has a beautiful smile, wide smile, and the teeth are back into the mouth. And all of this happening in 1 year of treatment. So we have 40 aligners plus 16 weeks, 56 weeks in total, and this is the result that we've got. We can never achieve this with fixed braces in this short time. We're at the end of the presentation. Thank you everyone for paying attention. Enjoy the rest of the conference and enjoy beautiful Budapest.